Welcome everyone to today's webinar. I am Mackenzie Bean with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Javed Siddiqui is the co-founder and chief medical officer for Telemed2U, a 100% telemedicine-based multi-specialty clinical practice. Dr. Siddiqui has been actively involved in telemedicine since 2002 and has been recognized as a national thought leader in the field. Dr. Siddiqui served as the medical director of one of the nation's top telemedicine programs at the University of California, Davis. In addition to being an infectious disease physician, Dr. Siddiqui is a recognized medical technologist who has previously held an appointment at University of California, Berkeley School of Engineering and served as the first medical director of the Center for Information Technology Research in the Interest of Society at California's Institute for Science and Innovation. Dr. Siddiqui co-founded Telemed2U in 2011. Telemed2U has pioneered work in developing and implementing telemedicine services and programs to hospitals and outpatient clinics. In 2012, the Agency for Healthcare Research and Quality recognized the telemedicine-based antimicrobial stewardship program developed by Telemed2U as an innovative program in healthcare. Dr. Siddiqui has lectured throughout the United States and internationally on telemedicine and serves as an advisor and board member to a number of telemedicine and healthcare technology companies. Dr. Siddiqui, I'll now turn the floor over to you.
Good morning. Thank you, Mackenzie. I really appreciate the opportunity. Good morning, everyone. Thank you so much for taking the opportunity to be here today. I'm really excited about our conversation for the next hour. We're going to be talking about implementation of advanced technologies to support quality initiatives and to reduce efficiencies for critical care patients. I look forward to your questions at the end. So what are we going to discuss today? Well, really want to talk about some of the emerging trends in healthcare. We also want to talk about some of the efficient delivery of actionable data, and finally, innovative technologies to improve quality metrics. That sounds like a quite a heavy challenge for 1 hour, but we'll do our best. So let's get started. Let's talk about emerging trends in healthcare. Now, when we talk about technology and innovation in healthcare, it's a very complicated situation. It's not just about implementing a piece of software or installing a new piece of hardware. It's really a very integrated approach because of the challenges of healthcare. But innovation has changed so many fields that we work in today. Just think about where we were 5 years ago, 10 years ago, and where we are today. But one of the things that's very unique to healthcare is that we have a combination of macro drivers as well as internal drivers. Each one of these is highly complex, but the key issue with healthcare is that all of these have to be connected. Right? It's not just one segment that you see here, but it's really a connection of all of these segments. And really, it's the partnership and how well. And if we're not working with each one of these segments together, we're going to find it very difficult to innovate in healthcare. So when you look at the law of diffusion of innovation, and I know many of you are very, very familiar with this, right? Unfortunately, healthcare tends to be a laggard, right? We tend to be very late to the game. When you look at something, an example is email. Most businesses were doing emails for years before healthcare was even willing to take a look at it. And being involved in healthcare and technology and innovation, one of the things that I've seen is a real challenge is that in healthcare, we immediately stop and say, oh, that won't work in healthcare. And I think what we really need to do is change that conversation. And that conversation really needs to be, this is interesting, how can we do it in healthcare? Because obviously we know the issues associated with security, with compliance, etc. We know those are critical and they have to be met. But we really need to focus that conversation on how we can do it, as opposed to just simply saying, no, that's not going to work in healthcare. Now, if we look at transformation of integrated care, Right? Each one of these circles is incredibly complex and has a myriad of elements within it. But so many of us are talking about population management, evidence-based standardization, right? We're talking about different types of information technology. But I think what we miss is the purple circle, and that's really collaborated integrated workflow. Because too many times we really think that if we have one of the others, well, that'll solve the problem. But it's not. It's not just simply, like I say, having a piece of software, or having a piece of hardware. What it is about truly having that collaborated integrated workflow so we can truly have this Venn diagram of where all three concentric circles meet, and that's really where we concentrate on that patient-centered focus. That, what we just discussed, really leads to this summary slide, right? So again, we have this continuum of care, right? And I think it's really important that we look at the entire continuum of care. Too many times we've been focused on just one or two elements of this care, right? And when we talk about integrated care models, we're really talking about how our customers, how our consumers of healthcare really connect with us. And they want to be able to have multiple touch points, but they want to have these multiple touch points throughout the entire continuum. It's not just about being able to email your doctor on an outpatient basis, but could you imagine being in a hospital, right, and being able to text message your physician, right, your hospitalist, right, being in the emergency department and being able, when you get prescriptions, being able to have them sent to the pharmacy that you want and getting an alert. Those prescriptions are ready as, when you're deciding whether you're going to go home or whether someone's going to pick up those prescriptions. That's the type of integrated care that our patients and our consumers are really looking for. Right? And if we can achieve that, we truly have an opportunity to innovate. So let's look at what we've done so far, right? One of the things that we've done is with regards to how our customers or our patients or our consumers, whatever you want to call them, what are those touch points in healthcare, right? One of the things that was really revolutionary was having call centers, right? Where advice nurses, that really allowed patients to feel, okay, I'm connected to my healthcare delivery entity, right? I'm able to call them, be able to talk to an advice nurse, be able to help someone can help me navigate it as opposed to get stuck on a phone tree. Right? For lack of a better term, retail medicine. Urgent care and drugstore-based mini clinics and store-based mini clinics, what are they providing? What is the reason why they're popping up everywhere? It's really about the convenience factor, right? If I can do my banking anywhere in the world, anywhere I am, why can't I have more touch points for my healthcare, right? Whether it's at a drugstore or whether it's at any other place, how can I get that? And finally, the area which I spend a tremendous amount of my time in, and that is the e-health environment, right? How can I get better access to that, right? How can I get access to healthcare where I am, right? Whether it would be through what we call synchronous telemedicine, real-time audio video conferencing, or whether it be through asynchronous or e-visits, right? Both have shown to be incredibly effective. So all of these is where we've come to so far in innovation in healthcare delivery. But the question is, what's next, right? What's the area that's going to be evolving rapidly? And my answer to that is it's really implementing these touch points within the entire continuum. And how can we do that, plus get the information to the right person when they need it in order to make a decision? That's really what I feel is what's next. Now, part of the importance of healthcare delivery is looking at where the investment funds are being placed. Right? This is data from Goldman Sachs Global Investment Research, and here you see is the increasing venture capital funds that are flowing into healthcare, right? Quite sizable, as you see here. And what are the areas of focus? Remote patient monitoring, whether it be heart disease, COPD, asthma, diabetes, etc. Think about a diabetic being able to get their blood sugars to an advice nurse who can then look at critical data and get that to a physician and then be able to implement all of that change, right, without the traditional, well, I need to make an appointment, I need to come in, I need to see the doctor. That's all important, but imagine having that remote patient monitoring and be able to deliver that kind of care. That's not only is that true innovation, but that's truly improving the quality of healthcare delivery. Telehealth, an area of tremendous opportunity and tremendous investment over the last 10 years. Again, really being able to deliver care where the patients are. And then finally, behavior modification, whether it's obesity, smoking cessation, overall lifestyle improvement, and the impact that will make on healthcare is truly, really unmeasurable. Okay. So now let's turn our attention to the patient-facing digital health, right? We've seen a significant increase in M health, right? We used to call that mobile health. Now we use the term M health, right? And those are really the apps and the devices. And there are literally over 250,000 of them in the market. Some of them have been FDA cleared, but really the FDA has stated, listen, this overwhelms us. We're going to concentrate on the medication and the device, and as far as devices that go inside the human being, and we're going to leave these applications alone, right? Now, health systems are developing a standardized process in order to utilize these apps, right? And I think several large healthcare systems have done this very well. And obviously, the key example is an organization such as Kaiser has done a tremendous job with regards to using mHealth in order to have better connected consumers, better connected customers of their service. And what do we look for? As easy as an app to make an appointment, an app to providers having apps with digital formularies on them so they know exactly what formulary their patient can be on. And also transitioning to centralized healthcare apps, more patient-friendly. We're really talking about the integration, not so much about what it does for the system, but what it does for the consumer, how the consumer appreciates using it and how easy it is to use. And it's really that user interface and whether they can make an appointment at an urgent care, at an emergency department, or scheduling an appointment with their primary care physician. Being able to do all that over mHealth really changes the overall experience of healthcare. Now, changing this conversation really would be amiss if we didn't mention the fact that we're changing to a more value-based models, right? I mean, obviously, when we talk about population health, we're always talking about the fact that we have to look at the cost of population health, right? And the management of costs across the continuum, right? We want to have lower cost environments, right? Not delivering care at the most expensive point of care, right? Obviously, we have to look at decreasing some of our fixed costs, and cost accounting analytics are essential to measuring performance, and I don't think we're utilizing them enough. So being an epidemiologist, you look at this, at the theory of concentric circles, right? So much of it has been at the center, the hospital-based, right? And now we're looking at different models within that hospital. Are you an employed physician? Are you a private practice physician? Also looking at diagnostics, right? How are diagnostics changing what we do at the hospital base, the most expensive point of care, right? Now let's go to the next concentric circle. What are we doing to actually integrate innovation and integrate connection to post-acute rehab, right? Pharmacies, ambulatory centers, retail and urgent care, home health services, community services. How is all that going to be connected, right? And what we really want to do is make sure that we're delivering value-based in all of this so we can achieve the population quality goals, but also help with regards to the cost environment that we're working in. Now, here's the dream. Here's where we want to go, right? When we look at the current care environment, you look at 80% being ambulatory, 15% being acute, 2% home, and 3% digital, right? And what we're really saying is that what the consumer, what the patient is saying, This is more of a balanced care model that they would like to achieve, where 50% of their healthcare delivery is really digital, 25% being at home, 20% being ambulatory, but only 5% being acute. Right? Really a redistribution of the pie, really looking at quality and efficiencies in order to create that better environment or changing that healthcare delivery environment. Okay, now let's change our discussion a little bit to how telemedicine is helping leverage technology and bring care closer to the patient, right? One of the things that being in this field for most of my professional career, one of the things that people are a little bit amazed for me to say it's not about the technology, right? The technology of telemedicine is simply the tool, right? What it allows you to do is to better connect the patient to the physician. And in this case, let's use the example of the medical specialist, because we all know there's a paucity of access to medical specialists throughout the entire healthcare continuum, right? So how can we get that medical specialist more centered in the ICU, right? And you go, well, how is that possible? How in the world are you going to use technology to improve ICU care? ICU care is where everyone has the most hands-on approach, etc. And let me give you an example. So I'm an infectious disease physician by training, and I apologize for not saying that up front. And I still practice infectious diseases. So I was asked to see a patient who was febrile neutropenic, so someone who was neutropenic from cancer chemotherapy, now comes into the ICU, has a fever, hypotensive, obviously one of the sickest types of patients that we take care of. And being a telemedicine-based physician, I was able to see that patient using real-time audio-video technology, see the patient, evaluate the patient, make my recommendations. But so the patient came in around late morning. I saw them early noon, but I was really concerned about this patient. So I connected with that patient probably 4 or 5 o'clock in the evening, and then before I turned in for the evening, I reconnected with that patient at their bedside using telemedicine, talk to the nurse, see how the patient's doing, see if any of our interventions have made some improvement. So that was a direct example of being able to leverage technology in order to provide closer monitoring of the patient. I saw that patient more times than if I was in a bricks and mortar environment and my office was located either within the hospital or outside of the hospital, right? Because all I had to do was 2 clicks on my screen and I was connected right there at the bedside, being able to see that patient. And I think that's really about how technology strategies can really deliver that increased quality of care. And there's numerous examples throughout all these continuums, but I wanted to share that with you because that's a real life example. Now, there's policy trends that are increasing access to telemedicine. California has been a leader, and my mentor, who I'm very privileged to work with, Vice Chancellor Dr. Tom Nesbitt at the University of California, Davis, has really been a leader and was really a key instrument and thought leader to passing both AB 205 and SB 171, which are some of the key legislative pieces in California, which have then been replicated in other states throughout the country. Also, we have the VA system that has really adopted telemedicine and telehealth, just simply in order as a workforce management, just simply as a way of increasing access to care, because they had a tremendous wait for their bricks and mortar environment, and now you can touch the patient more, interact with the patient more, have a better quality and level of care by using telemedicine and telehealth technologies. Finally, what is telemedicine in a hospital can deliver? These are some of the value-driven inpatient care models that we have shown. Increased access to medical specialists, which I just talked about. I think improving quality of care. I think whenever you have more medical specialists able to see that critically ill patient, there is a quality of care improvement. Obviously, a differentiator in a competitive market for the hospital to be able to say, no matter where we are, we're able to get all these medical specialists here. Obviously, improve patient satisfaction and retention. One of the key examples we've seen is that patients donating to the giving gifts and donating to the hospital, specifically saying, I'm donating this because of the experience that I had through telemedicine. We've seen that at multiple of our hospitals. Reducing transfers, and when you're talking about transfer DRGs, right? By having access to medical specialists there at your hospital through telemedicine, you can reduce that need for transfer and therefore reduce your DRGs. Also reducing that 30-day readmission rate, then obviously reducing ICU hospital length of stay. And you go, well, that's rather a bold statement. How is that? Hang tight with me and I'll share with you some data regarding that. Now we've been talking about ICU and centered in that critical care patient, so let's continue to focus on those ICU patients, right? There is variance in ICU practice, as to some as strange that may seem, or to others that go, of course there is. You have to look at all these different metrics, right? The qualification of providers, adherence to best practice, hours of operation. I don't think anyone really thinks about that. Bedside intensivists, right? Are you in a teaching or non-teaching environment? All of those things have a tremendous impact on the variance to ICU practice. Right? This is where we are currently in the digital age of healthcare, right? So here you see a neurologist evaluating a patient who had a stroke, and where every minute, every second matters. And you see that this is the intersection of telemedicine, the electronic medical record, the PAC system, so you have the digital imaging, being able to, all of that information being able to harness by in one environment, and being able to see the patient being able to see the physician, and being able to make that intervention, right? Really, as Dr. Nesbitt has taught me and has repeatedly said in multiple presentations, really the essence of healthcare is getting the right information to the right provider so they can make the appropriate intervention. So it's information to the person so they can make an intervention. And that's what we're doing here. And this is not science fiction. This is what we're doing today. So what are some of the acute issues that Tele-ICU deal with? Well, obviously, consultations from a number of specialists. Again, being an infectious disease physician, I think we play a critical role in the ICU. Obviously, antimicrobial stewardship. Then you also have other complex issues, whether it be ventilator management, whether it be dealing with cardiac issues, etc. All of these can be dealt with from a telemedicine standpoint. And we've proven this. So here's that data that you were talking about. Wonderful paper from Dr. Cole and colleagues that was published in the Journal of Telemedicine and Telecare in 2012. And what they showed, and I know this is remarkable, but what they showed was that by having telemedicine within the ICU, right, what they found was they found, and this is quoting them, was associated with a profound reduction in length of stay in the ICU, ICU mortality, and hospital mortality. And those are, you can't get more profound statements than that. And what they really showed that by having the ICU, the telemedicine model within the ICU really allowed for increased access to care, increased specialists being able to provide more monitoring, more care over that patient, resulting in the decreased length of stay in the ICU, decreased ICU mortality, and overall decreased hospital mortality. So with that said, let's continue our conversation and discuss efficient delivery of actionable data. So the EMR, as painful as it's been, and I know that many of you have got a lot of blood, sweat, and tear, maybe even a little bit of PTSD over your EMR implementation. But what it really allowed us to do is have a foundation for real-time structured clinical data capturing. And I don't think that was stressed enough, but that's really the reason for it. And really, the early adopters really embraced the EMR and the data, and it really was a catalyst for change on a multitude of levels, but patient safety being the key. Now what we need to do is really leverage those EMR systems in order to really develop actionable data, right? We're having all this data come in. How can we evaluate that data, synthesize that data, and then be able to develop an actionable item? And one thing I'll tell you, it's one of the passions of infectious disease, something that I don't think we ever thought would be a reality, but we're getting closer to it, and that is something called a real-time antibiogram. To be able to see changes within antimicrobial susceptibility or antibacterial susceptibility in real time, to be able to say, okay, this month what we saw was this antibacterial had a higher degree of resistance, so let's start using this other anti-infective as our workhorse for this disease state, and really being able to follow these things in real time. That's been a challenge. It's been a tremendous opportunity, and I think we now have the technology in order to be able to bring that to fruition. So, using that as an example, again, as I mentioned before, we had millions and millions of points of medical data, but now we're able to harness all of that within our electronic medical record. Now, how can we look at that electronic medical record over sepsis? And sepsis due to a bacterial infection, overwhelming bacterial infection resulting in hypotension, resulting in multi-system organ failure. How can we deal with that? Right? Well, right now, the data within that EMR, for lack of a better term, really does trickle in over 48 to 96 hours, right? We're constantly looking for those little bits of data that are going to help us make that important change so we can have a actionable item that will truly have an intervention. So traditionally, it's been, if we look at one example, that's blood cultures. How can we make a difference with regards to blood culture, right? How can we identify the organism within the blood? How can we get the appropriate susceptibilities? And then how can that result in an actionable item, i.e. changing the antibiotic or making sure the patient's on the appropriate antibiotic so you can help a patient get improve? And that's really, we're talking about all those measures that you saw in Dr. Cole's paper. If we can do that, we can reduce length of stay in the ICU. We can decrease ICU mortality and decrease overall hospital-based mortality. So data has to be that catalyst for change. So traditionally, when you look at microbiology lab, there's data generated in the microbiology lab. We now have ability to do rapid diagnostics, and there's several examples of essential rapid diagnostic technologies. But what we need to do is get that information from those rapid diagnostics, not only into the EMR, but to be able to get it to the right person, to the right provider, to the right physician, so they can make that key decision. Again, using that example of the real-time antibiogram. But one of the things that we forget about is the human interface, the time to action, right? So we've gone through the EMR implementation. We've done that, right? We now have these new real-time, these rapid diagnostics where we can help support a real-time antibiogram, right? So we've created some actionable data, but the question is, what's that time to action, right? Because just because the data is available, does it really mean someone's paying attention to that data and actually doing something about it, implementing that change? And that's really where that human interface comes in. And I think this is an area where we need a lot more work in. We've done a tremendous amount of work in the other areas, but at times we forget about this. And I think this is the real challenge that we face. Now, if we're able to do that, what can we do, right? And how can some of these federal health IT mandates help us do that? Well, obviously, we can talk about achieving adoption and information exchange through meaningful use in IT. We can talk about improving care, improving population health, reducing the cost of healthcare through the use of IT. We talk about all that. But if we're truly able to do that, that's when we elevate to goal 3, and that's where we inspire confidence and trust in health IT. right? And I think as much as the term crossing the chasm has been used so much in order to go from innovators to early adopters, in referring back to the law of diffusion of innovation, what I think we really need to do with regards to this is really, how can we have these healthcare-based IT models that are in hospitals, that are in our different healthcare settings, that can really inspire confidence and trust in healthcare. I think that's true. I'll give you an example that that I think really made a difference at one of our hospitals just a few months ago. We had a patient come in with clearly signs of meningitis. We were able to take their CSF, their cerebrospinal fluid, put it into a microarray system for rapid diagnostics. That let us know that patient had human herpes virus 6 within 2 hours. So from the time that the lumbar puncture was performed to the time that we realized that this patient's meningoencephalitis is really due to human herpes virus 6, right? We would then be able to say, okay, let's stop those antibacterials, let's continue the antivirals, let's continue the support to be able to tell the patient and the patient's family, we have a diagnosis, right? That inspires confidence. That inspires confidence not only in the providers who now go, okay, having these types of this type of data and being able to have access to this type of data, that is truly an actionable item. That is truly something that I have confidence now in, but it also has confidence in your consumer as well as the family to say, wow, we came to the right place, because within a couple of hours they knew exactly what was going on. They were able to tell us what the cause of this was, as opposed to, well, we're going to send it out to a specialty lab, get data in 4 to 5 days, and we'll just try to support your family member during this time, and we're just going to throw everything in the kitchen sink at them. Now we can be far more strategic. That then inspires that individual, inspires the provider, and it really achieves rapid learning and technology enhancement. So you can really see how we're getting there. We're getting to the point where we can help transform healthcare delivery. Obviously, value-based performance is going to be critical. Everyone is talking about value-based performance. And I think that we would be amiss to not say that there's tremendous opportunity for innovation, tremendous opportunity for technology, and there's tremendous opportunity to leverage those into helping us meet these value-based performance measures that we're all going to be held by. Okay? So if we go back to how do we get from the lab to the bedside, I mean, this is a very, very elementary or basic flowchart on how do we get that information. Okay, great. So now we've been focusing for the last decade on how we get all that information into the end result. Here, the end result is the electronic medical record. But one of the things that we need to talk about is how do we make sure that the providers are seeing that information and acting upon that information. That's the next step. That's the next piece of the puzzle. So obviously there's a lot of obstacles in decision support systems. You all are very, very familiar with that. But what we really need to do is look at how we're going through these steps 1 through 4, right? So we've focused so much on, we've identified the need. We're trying to develop some intervention, right? But it's really that implementation of the intervention and then evaluating those, how those changes can then make an impact. And that's where we are, right? And that's really where we need to concentrate on. Now, part of the problem is, one of the things was, okay, we're going to put a pop-up windows on their EMR and we're going to create alerts. But what if that happened? It just caused everyone just to be desensitized by them. Say, okay, I'm sorry, I get 100 alerts a day. Who knows what this is? Let me just close this box, close this box, close this box, so I can actually get to what I'm trying to do. We have to come up with better, innovative ways of doing that. Right? And again, it's all about leveraging the data that we already have in our electronic medical records to improve hospital efficiencies. So we need to concentrate on that user interface, right? So how does increased data velocity tethered to a decision support, right? That's that last mile, to use a phrase, that we need to achieve, right? What we really want is, and I know supercomputing and has thought about this, and I think that as we move forward, this is some of the hopes and aspirations, is that activities and resources through analysis will help forecast admissions. Say, okay, this is a patient with community-acquired pneumonia that has an increased risk for hospitalization, so let's follow them more closely, whether it be through remote patient monitoring, whether it be to connecting with them in the home through telehealth, and then we can make a better assessment as far as, okay, you know what, we started you on antibiotics, you're still not getting better, let's have you come in, right? And be able to forecast that admission, as opposed to the patient getting short of breath in the middle of the night, calling an ambulance and having them come to the emergency room. And now this type of care that we've been doing traditionally is that we found is so expensive and so reactive, as opposed to being much more forecasted and planned. Obviously, they'll never be 100%, but again, using that example, we can do better. And then obviously, what we want to do is to be more efficient and process the information more efficiently. So how can innovative technologies improve quality metrics? So let's use an example in order to take a look at this, right? And obviously, everything that we've been talking about leads to this phrase, right? It's the phrase of implementation science. And I know it's been a very popular phrase. It's probably the new population health buzzword, but really everything that we've been talking about right now really is implementation science. And that's the reason why it's so important. It really is about taking all that information, all the work we've done over that last decade, and making sure it's getting to the right people so they can make the right intervention and make the correct change. So being an infectious disease physician, let's use the example of the challenge of empiric antibacterial therapy. And we'll use a real world example. Okay, so when someone comes in to the emergency room or comes into the ICU, and clearly you assess, okay, this patient's having an overwhelming bacterial infection. Well, we initiate anti-infectives. Well, how do we initiate them? Well, a lot of times we initiate them based on a local experience. That's called the hospital antibiogram, which really is the roadmap to how to treat infections. And I think that far too many times that's missed. Then it's up to, well, what's your experience? What's the anti-infective that you're most comfortable with in using? And unfortunately, we see that far too often. But the problem is the organisms are becoming more educated. The organisms are developing more resistance. The patterns of resistance are changing, right? So that comes into play, right? So now, you try to use epidemiology. Is a patient coming from home? Is a patient coming from a skilled nursing care facility? Is a patient coming from another hospital, right? All of those factor into your choice of anti-infective. Now, this is something that I talk about quite a lot by doing in my field of doing antimicrobial stewardship. I often ask people, physicians and other hospital providers, what's the number one antipyretic used in the hospitals? And I choose my words very, very carefully. Antipyretic. And my answer is vancomycin, piperacillin, tazobactam, which one of my colleagues from University of Miami at Coral Gables once said, peanut butter and jelly. And I said, you're absolutely right. Everyone that comes in, whether you're coming in for paronychia or whether you're coming in for febrile neutropenia, likelihood you're going to get vancomycin, piperacillin, tazobactam, right? Gorillacillin, napalm, the scorched earth philosophy, right? And that's what we're currently doing. But is that really the right way of doing things, right? What we really want to do is move to optimal therapy, and that's optimal therapy based on the susceptibility of the specific organism that the patient has. That's the goal. Right? So wonderful data from several individuals. Dr. Culler from Washington University in St. Louis has been a pioneer in looking at this type of data and continues to present this data, as well as a wonderful paper by Dr. Kumar in Critical Care Medicine in 2006. Right? For every hour of delay in targeted antibacterial therapy, there's a 7.6% increase in mortality. That's from Dr. Kumar's data. Right? And what you see here is that time of hypotension, right? And when are you going to get effective anti-infective, antimicrobial therapy, right? Time to appropriate antimicrobial therapy is critical. And it's not just throwing everything in the kitchen sink at the patient, but it really is getting to that optimal therapy. What's amazing is that 25% of patients with bloodstream infections, right, are on appropriate therapy, right? And I'm sorry, are on inappropriate therapy. I apologize, are on inappropriate therapy, and that therapy needs to be escalated, right? There's two models. There's escalation of therapy and de-escalation of therapy, okay? We're going to talk about that in just a bit, right? 52% of the patients with bloodstream infections require susceptibility. So that's antimicrobial susceptibility testing results to move from an ineffective to a more effective antibacterial therapy. Okay. So what is the consequences of this undertreatment? So this is escalation. Escalation meaning you start with something, you see the patient isn't getting better, and now we're going to move on to gorillacillin. Okay, that's escalation of therapy. We clearly know with regards to escalation of therapy, again, work by Dr. Kalev, Dr. Schur, Dr. Kumar, and others, right? It leads to more drug-resistant organisms. We know it leads to a longer length of stay in the ICU, and it leads to a higher mortality. So, more bacterial resistance, increased length of stay in the ICU, higher mortality. None of this is good. This is nothing that we want to achieve. Right? So what about throwing everything in the kitchen sink at the patient? Well, unfortunately, we know far too commonly 30 to 60% of antibacterials prescribed in the ICU are either unnecessary, inappropriate, or suboptimal. Data that's published in Critical Care in 2014. Right? Overtreatment with broad-spectrum antibacterials results in multi-drug-resistant organisms. Again, if we continue to use vancomycin and piperacillin tazobactam as our choice of antipyretic, and everyone gets this this class of antibacterials, well, I always say nature abhors a vacuum. So if you're trying to kill off every bug known in existence, what are you going to get? Well, one of the things you're going to get are Clostridium difficile-associated diarrhea, right? A lot of this is a balloon. You squeeze it on one side, there's going to be a reaction. And many of the hospitals that I work with and that we speak with, we hear the situation. Well, you know, we really have a high incidence of Clostridium difficile-associated diarrhea, and we really need to address this. Well, what are you doing as far as antimicrobial stewardship? Right? What's your use of vancomycin, piperacillin, tazobactam? What about your use of proton pump inhibitors in patients who are on anti-infectives? So if you're not addressing any of those issues and you're just saying, well, gee, we have a issue with Clostridium difficile, it's exactly what we're doing that's causing this. We're creating the perfect environment for this issue with Clostridium difficile-associated diarrhea. So let's look at the reality of empiric therapy today. So this is looking at generic antibacterials that are prescribed for prospective or empiric treatment of bloodstream infections, right? What we found is that 81% of the time there's overtreatment or the need for escalation, and only 10% of the time the need for de-escalation. So what that says is that 90% of patients with bloodstream infections are really on suboptimal therapy for anywhere from 30 to 36 hours. And that's really until they can get susceptibility results in order to make an appropriate antibacterial choice. Kind of an alarming statement. Now if we look at the escalation that's required, 10% of patients with bloodstream infection are on ineffective therapy for that 36 to 90% of the hour without having access to rapid antimicrobial susceptibility testing, and that clearly increases the risk of mortality. Okay? Now, if we're trying to de-escalate, well, we're trying to prevent adverse drug reactions, right? So 80% of the patients on bloodstream infections are on suboptimal therapy for 30 to 36 hours. What we really want to do is we really want to reduce the time from empiric to confirmed therapy for all patients with bloodstream infections, right? And that's critical to improving the sepsis-related outcome. It's critical that we get those susceptibilities, not only that we can determine those susceptibilities, but get those susceptibilities to the right person so they can make the appropriate intervention. That's what we're trying to achieve here in this example. And technologies already exist for doing that, right? When you look at Accelerate Diagnostics PhenoSense system, right, that's exactly what it does. right? It reduces the time in order to get from the time you get the blood culture to the time you get identification of the organism, the time that you get antibacterial susceptibility testing. It reduces that time dramatically, right? So it can reduce that by over 40 hours. So you can decide when's the right time to escalate, de-escalate, or even discontinue treatment. All of that falls into the measures that we've all been talking about. Okay? Here's data from the University Hospital in Augusta, Georgia, using the Accelerate PhenoSense system, and what they found was that by having the Accelerate PhenoSense system, the overall bloodstream infection mortality, right, dropped by 7%. And that's remarkable. That's a reduction of 36% since they implemented the Accelerate PhenoTest system. So again, getting the right information to the right person in order to make that decision. That's what we're talking about. And that's why implementation science is so important, is because if you simply calculate or determine what the susceptibility is, but you're not able to get that information to a provider in order to make the right decision, to either change that anti-infective or de-escalate that anti-infective, that's what needs to be done. And that's where we need to now focus on. Because as we're looking at all these value metrics, that example will impact mortality, it'll impact effectiveness, right? 45% of your overall score when you're looking at quality metrics, 45%. So how can all this technology and these examples of these technologies improve quality? Well, we've already talked about telemedicine, how enhancing its utilization really helps with acute intervention, also helps with patient surveillance and proactive intervention. Right? I think this has clearly been shown in the fields of infectious diseases, in the fields of stroke medicine, the best. Also, state-of-the-art diagnostics. You know, being able to have rapid diagnostics so we can make those interventions, so we can help with regards to length of stay, we can help with regards to readmissions, right? Also, integration of robust antimicrobial stewardship programs that can also impact mortality and decrease length of stay and duration of treatment, right? Antimicrobial stewardship is so important and tied so directly into rapid diagnostics, getting that right information, right? And then obviously we have electronic data integration. How can we standardize the approach for these therapeutic interventions? How can we track the intervention impact, right? What's that delta from the time that the data is available in the EMR the time an actionable item occurred, right? That improving the process, right? Getting the right information to the right person so they can make that right decision. Okay? So we know that getting faster susceptibility data with MIC data, getting the right drug in the right patient helps reduce 30-day readmission rates, decreases length of stay, and reduces adverse drug reactions. Specifically, when you're talking about nephrotoxicity, you're talking about Clostridium difficile-associated diarrhea. Wonderful data by Dr. File and Dr. Bartlett, published in Clinical Infectious Diseases in 2014. That really leads this whole quality improvement philosophy, right? We have to have not only rapid change, but broad engagement. We're really we've been focusing on so much of capturing the data. Now we really need to focus, that Kaizen focus on patient flow and human efficiencies. So that, coupled with that patient-centered actions, can result in impacting those targets that we so want to achieve: quality, experience, financial, and then also help with the outcome metrics of safety, mortality, quality metrics, and all of that contributing to the cost of care. So, in summary, I hope I was able to share with you this morning some of the data regarding emerging technologies and integrating better decision support, also overcoming some of the fear of change to improve quality. And I think, in healthcare, that's an issue I don't think we discuss enough about, and one that we absolutely have to face. Also, trying to get out of the reactionary mode. Trying to be able to say, okay, we're going to prepare our teams for tomorrow by having some innovation plans for today. and we're going to invest in emerging technologies that can integrate for better patient care. So again, thank you for the opportunity to engage in this conversation with you this morning. I welcome your questions, and thank you again for being here, and please look forward to your questions.
Thank you, Dr. Siddiqui, for that fantastic presentation. We'll go ahead and begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to get through as many questions as we have time for. And it looks like we already have a ton of questions rolling in. And the first one is, can you please elaborate on real-time antibiogram? Does any hospital have access to this real-time antibiogram?
Thank you. That is a great question. And that's why I said that's the goal that we're trying to achieve. No, I'm not aware at this point in time that anyone has a real-time antibiogram. But I wanted to use that as an example of how we can use our information technology, our electronic health record our electronic medical record that we have now, coupled with rapid diagnostics in order to help create that real-time antibiogram. That's been a goal of infectious diseases for a long time. I think that we're on the precipice of being able to do that, but that's definitely something that we hope to see in the not so distant future. I really think it's in the near future.
Wonderful. Thank you for clarifying that, Dr. Siddiqui. The next question is about optimal therapy time, and it says, do you believe that CMS will use the optimal therapy time as a benchmarker for sepsis?
That's another outstanding question. You know, I think that's a complicated answer because, you know, for far too long, we looked at, for community-acquired pneumonia, was getting antibiotics immediately. And unfortunately, what that resulted in was a lot of patients getting anti-infectives who didn't need them. So we have to be very, very careful about just saying that we're going to use time as a measurement. I think that the incredible work that Dr. Culliffe and Dr. Kumar and Dr. Shore and others continue to do with regards to optimization of anti-infectives in the ICU can lay the groundwork in order to really look at that. But I don't think we can't look at it as a vacuum and just go, okay, time to optimal treatment will be X, and if you're not if you're outside of this range of X, we're gonna say you have bad quality. We have to be real careful of that, because what's going to happen is, and we've seen this in the past, is that it's going to result in overuse of broad spectrum antibacterials. So we have to create that metric very, very carefully.
Absolutely. I think that is a great point. Thank you. Another audience member asks, are there any synergies with telemedicine and cutting-edge diagnostics?
Absolutely, I think there are. I think that telemedicine coupled with the microarray has been demonstrated and is being demonstrated on a daily basis. The example I gave you, that patient was seen in the patient that I said that who had meningitis. That patient was seen in the emergency room through telemedicine. The rapid diagnostics was performed, and within 2 hours, the diagnosis of human herpes virus 6 was made. That patient, again, through telemedicine, reconnected with the patient, reconnect with the providers, and being able to make that intervention. So I think that is being done. I think we're going to see much more of that. And I think as we see the increased utilization of the Accelerate PhenoSense test, that's another key example of how you can get that type of data, get that rapid susceptibility testing, use telemedicine to get your provider to the bedside in order to make that intervention sooner, have engaged in those discussions. I think everything is there for that to occur. We just need to be implementing that and utilizing those resources.
Great, thank you again, Dr. Siddiqui. The next question is, how would you propose clinical data be extracted and used by a FQHC for quality improvement? Can you elaborate on the data sources and how to assure the quality of the data?
Thank you. That is a incredibly important but highly, highly complex question. I wish I could give you a 15 or 20 second response to that. I think the the best direction I can give you to start that conversation is, what are you trying to achieve? And I don't think we think about that. Okay, well, we have millions and billions of points of data, but what are we trying to achieve? Is our quality metric at an FQHC, are we going to reduce our hemoglobin A1C in our diabetics? Are we going to have less patients with congestive heart failure admitted to the hospital in decompensation? Are we going to test all of our patients for hepatitis C? What is it that you're trying to achieve? I think once you decide on what is it that clinical intervention is, or that clinical metric that you're going to impact, then you can look at what's the right data. Because there's no way you can harness all of the data that you're collecting in your EMR at one point in time. It has to be directed and has to be focused. Think about what your goal is first, and then make sure you're capturing that data, and make sure how you're going to aggregate that data, synthesize that data, and then finally that last step that I hope we tried to emphasize so much today: how are we going to get that data set or that data to the provider so they can make an impact in a patient at an FQHC? All of those things need to be thought of, but it's a long-term process, but I think it's an incredibly important endeavor to begin. I'll leave it at that, and then I can also say, as you do that, please present your data, publish your data, because we need more real-world examples of this.
Absolutely. Thank you for elaborating on that. Another audience member would like to know, what are current innovative approaches in microbiologics?
Well, I think that there's, kind of in a golden age of rapid diagnostics and microbiology. I think the microarray systems have been phenomenal. I think the rapid susceptibility testing in the pheno test from Accelerate, I think those have been two of the most revolutionary pieces of technology in microbiology. To say that we can improve diagnostics, that we can get that essential information faster to the provider to make a decision or make an intervention faster, I think that is key. So as we're coming up with better diagnostics and better tools in the microbiology lab, how we have to have the clinician being involved far earlier, because unfortunately, if we come up with a wonderful data point in the microbiology lab, but that information is not disseminated and no one takes action for that data, that is a tremendous loss. It's a lost opportunity. To me, that's even more painful than never having that piece of data before, because now you had that data. I mean, the example that I gave you, the patient with human herpes virus 6, if that was determined within 2 hours, but no one picked up on it until 14, 16 hours later, that would be so disappointing and such a loss for all the work and all the effort that was made in order to have that piece of data available within 2 hours. So I think that implementation science and having actionable, being able to have that human interface so you can take that actionable data and create an action from it, that's so important, and that has to be something we focus on as we move forward.
Yeah, that is really interesting. Thank you. It looks like we have time for one more question. And the final question is, how do you manage alarm fatigue with more information available to clinicians electronically these days?
That is a great question. I don't have an answer to that. And I think that's really where that really is the challenge for implementation science, because we really have to come up with a better solution than just abrupt alarms. We really do. We really have to talk to the providers, look at how the providers actually work, look at what's going to be useful to them, and and help them, not overwhelm them, because the pop-up window, the alarm idea was a wonderful idea, but the problem is that we had so many data points that everyone just attached an alarm to, that all you got was a screen full of alarms and you couldn't see the forest from the trees. So I think there's not going to be one solution to it. I think there's going to be a myriad of solutions, and I think there may even be specialty-based solutions. For an ICU doctor, here's how they want the alarms. For a surgeon, here's the alarms that are critical, and this is how they want them. For this specialty, we need it this way. For this specialty, we need it that way. I think we need to take a much broader scope rather than looking for a one-size-fits-all, but try to have systems where the actual end user can maybe even play a role in designing that, not only which alarms they want, but how they receive those alarms.
Wonderful. Well, that is all the time we have left for today. I want to thank Dr. Siddiqui for his excellent presentation and Accelerate Diagnostics for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.